Assalamu alaikum. Hello, everybody. Uh, Glad to be here. Thanks to the organizing scientific committee. My task is to make a case for TAVI and low surgical risk patient. I have no disclosure. This will be my objectives. I will mainly concentrate on the new evidence on low surgical risk. So we know since first TAVI implant in 2002, the number of TAVI cases have been exponentially increased. And in 2019, the number of TAVI performed has exceeded the surgical valve. This is the same trend also have been noticed in Europe as well. So going back to the guidelines, we know in the American guidelines, the age limit for TAVI was to go for patient 80 and above with less than 10-year life expectancy, and less than 65 is for SAVR, and between is shared decision making. However, in the new European guidelines, we can see that the age limit has increased or lowered for the TAVI as patient 70 and above with suitable anatomy. So both guidelines highlight the importance of patient age and life expectancy as well as the surgical risk. So TAVI came all the way from prohibitive risk to high risk, then moderate risk, and currently the era of low surgical risk evidence. So we're going to review the few trials have been done to address this topic. So starting with the Partner 3 trial, we recently published the 7 years outcome. This was a 1,000 patient population with mean age of 73. We can see that at 7 years, there is no difference in composite endpoint between surgery and TAVI. When you look at individual risk endpoint, it's the same. There is no significant difference. Worth to mention that at 1 year, TAVI had a favorable outcome. Looking at the valve performance and hemodynamics over the 7 years, both did well, the SAVR and TAVI group. And the rate of prosthetic valve failure and the need for reintervention were similar. The other study is Evolute Low Risk Trial. We have a 5 years outcome. This is more patient, 1,400 patient with mean age of 74. Both group had comparable composite endpoint and individual endpoint. You can see all the individual endpoints are similar except for higher AFib on surgery group and higher pacemaker on the TAVI group. Looking at the valve performance, we can see that TAVI had a lower mean gradient and higher effective orifice area than SAVR. However, the rate of mild and more paravalvular leak was higher on the TAVI group. Moving to a Notion trial, although this is a small study, but we have recently a 10-year outcome. So this involved 280 patients with a bit older population, 79 age. So the outcome was comparable between both group at 10 years. And all individual risk factor outcome actually were similar except for more atrial fibrillation on surgical group and more pacemaker on the TAVI group. Valve performance at 10 years, both actually did well. However, TAVI had lower mean gradient and higher effective orifice area. Again, with more paravalvular leak on the TAVI group. When they look at severe prosthetic valve dysfunction, surgery group had a higher structural valve dysfunction, but this was mainly driven by presence of higher severe patient prosthesis mismatch in the SAVR group, which was a bit higher than the usual. It's around 32%. The valve thrombosis and endocarditis were similar, and the need for reintervention was similar between both groups. This is another interesting study from the same group, Notion 2. We have 3 years follow-up. It's include 370 patients with a younger actually population of 71 mean age, and around 43 of the population was 70 and younger. And it's a kind of mixed population. Around 100 patients had bicuspid aortic stenosis, so both bicuspid and tricuspid. So when they look at 3 years follow-up, actually there was no significant difference. We can see there is numerically higher stroke and rehospitalization in the TAVI group than surgery. However, this did not reach clinical significance. When they look at the stroke, especially because it was higher, and divided to non-disabling stroke or disabling stroke, the non-disabling stroke was significantly higher on the TAVI group than surgery. And again, the same observation of new atrial fibrillation surgical group and new pacemaker on TAVI group. Valve performance was good for both group and comparable. Again, the same rate of reintervention and valve thrombosis. Interestingly, when they divide the two cohorts, the cohort into two groups, tricuspid cohort and bicuspid cohort, we can see in tricuspid cohort both did quite similar. However, when they divide the bicuspid group, you can see that the higher, numerically higher rate of worst outcome in TAVI group, but was still not significantly different. This was mainly, the difference was mainly because of stroke and rehospitalization. You can see numerically really higher than surgery, but was not statistically significant. This is a randomized trial, including all the 6 randomized trial done for meta-analysis for all the 6 randomized trial. And it's also emphasized the same thing as 30 days and 1 year outcome was in favor for TAVI. However, at 5 years, there is no difference between both groups. So this is a kind of roadmap I've seen when I attended one lecture. Thought I should bring it to our discussion. So for lifetime management of patients with severe aortic stenosis, if we assume that the valve durability for both surgical and TAVI is around 7 years, and you have a patient at 55, patient can go for TAVR first, then redo TAVR, later on one surgery with explant and SAVR, and TAVR again. However, if the patient started with SAVR, then we'll go for TAVR again and explant. So the first patient will undergo one lifetime surgery, unlike the second one with 2 surgeries. However, surgeries still have a major role in those patients, especially patients with concomitant procedure, like CABG, endocarditis. And in case of hostile anatomy with difficult TAVI access, and still question mark about the bicuspid valve, we need more data. And at the end, the crucial point is the heart team approach and with careful anatomic analysis of the valve. And low surgical risk does not mean always a young patient, and young patient does not mean always low risk. Thank you.